Okay, so I'm just going to do a real basic overview of endovascular stuff for our student Rachel here. We're going to talk about just the very basics, and anytime you're thinking about endo, I just don't want you to be confused. These things are just wires and tubes. There's really nothing else. There's two options. There's wires and catheters. So wires, you want to think about a couple different things. So they range on a scale from soft to firm or stiff. Everybody's going to use different wires, but in general, things that are on the softer side are going to be things like glide wires. Oh God. Glide wires. And there's a glide soft and a glide stiff. And these are all 0.35 wires, which is 0.035 inches. Why we have inches and then centimeters, I can't explain that. Then we have a glide advantage, which is a pretty stiff core, but it has a 25 centimeter soft tip that's like the traditional glide wire. As we go up, then we have the amplats, and these have different length tips. You can get ones that are short or long, so like 7 centimeter or 1 centimeter, depending on how deep you are in a branch and how much stiffness you need. And then our most stiff is our Lunderquist. And I'm leaving out a lot of wires, but this will at least give you an idea for 0.35 wires, kind of what you're dealing with. The next thing you want to think about is shape of the tip. So in general, you've got not a ton of options, but you can have a straight tip, angled tip, and then this is called a safety tip or a J-tip. So things that would be in the straight tip or angled tip, those are going to be all the wires you just saw above. There's also double curve Lunderquist. So these are special curves that are big enough to go over the aortic arch and then curve again so that you bounce against the aortic valve. The safety tip are things you're going to see on Rosen wires, and so a Rosen wire is kind of be here kind of in the glide advantage ballpark of stiffness, not as stiff as an amplats, but stiffer than a soft glide. And those are really handy because they don't have that soft tip on the end, which is going to really not support you when you're trying to deliver an interventional tool. And then the other thing you're going to think about is size and length. So the size wires, generally 0.014, 0.018, 0.035. And there's also 0.038, but not commonly used. So 0.035 is going to be your workhorse, which you're going to start with most of the time, and then you're going to move down to those other size wires if you're working in small vessels. And just there's a ton of wires. You can go on Endovascular today, and they have a whole list of every wire that's available. But this is just kind of a general overview. And then when you go to links, I think of the links generally on if I'm trying to work on somebody's leg. How far do I need to go? So if I'm just trying to get a wire to the end of somebody's leg, I need about a meter. If I'm going to try to get a catheter there, I need a meter within the person, and then I need a whole meter on the outside of the person. So the links are generally like 180 for a short, 260 for a long, and then 300 and 300 plus. With the 300 plus, these are usually going to be 018 wires or smaller wires because you're getting down into your tibials. But these short wires and this is generally what we mean when we say short and long. Catheters, there's a billion different options, but things that are common, you want to think about mostly what the tip is shaped like, because the tip is really going to determine what the catheter does. So straight tip catheters aren't super common, except for with quick crosses, which are a tapered catheter, so that allows you to get that catheter down the leg a little bit better because they're tapered at the end. You're going to see a lot of angled catheters because that gives you the ability to turn that catheter and put your wire down in different areas. There's something called a pigtail catheter, which looks like this, and that's just an atraumatic catheter. These are usually flush catheters, so you'll see on the shaft that there's a lot of little holes that allows you to pump out a lot of contrast at a high pressure without damaging the artery, and you get a better picture because you don't get just a jet of contrast going up the arm. And then you're going to see things like our Omni catheter, which are great for going up and over a bifurcation, and things like a sauce. which looks like this. And this is handy for a lot of things. You can use it for up and over, but it's also handy to drag down the aorta or along the arch. And this little leg will actually stick into the ostium of different arteries, and then it's really easy to get your wire inside that ostium. With catheters, generally the length is going to start at 65. This is the basic length. And then you're also going to see hundreds, and then you're going to see longer than that. And these are going to be different sizes to go with the wires. And a sheath is essentially just a catheter with a valve on the end, and that valve usually has a flush port on it. So don't get too worried about these. So you can use catheters as sheaths if you put one of these on them. So like really small catheters, like a 5 French, sometimes you can make those out of a catheter. But just don't get confused at what a sheath is. It's just a tube with a valve on it. There's different kinds of valves. The ones that I think you should know are check flow, which is essentially a rubber valve, and then a dry seal, which is a balloon. So it's just a balloon at the end that's filled with air or with fluid, and that keeps blood from coming back at you. Just know that the dry seal also has a hydrophilic coating, so it likes to slide out. So don't try to back things out unless you really have a hold of that. Just from personal experience, that's not fun. And then let's talk about interventional tools. So very basic things: plain old balloon angioplasty, POBA. You have DCBs, drug-coated balloons. You also have cutting and scoring balloons, which are things that you can look up on your own. But in general, you want to know kind of what size you're looking at for these things. So most of these are going to be 5 French, which is handy. When we talk about stents, I want you to think about them in 2 different boxes. So there are 2 different kinds of stents. There's covered, bare, and then self-expanding and balloon expandable. So when we're talking about a covered stent, that just means that there's fabric over the whole end of it. Bare, obviously, is just the cage. Self-expanding is going to be softer or more flexible. It's going to have less radial force or hoop strength. Where the balloon expander is going to be stiffer and have higher hoop strength. Higher hoop. So a covered self-expandable would be something like a Viabahn. Viabahn, because we're from Germany. So the Viabahn is great in areas that have a lot of movement, like an external artery or something in the shoulder. You would never want to put a balloon expandable there because all that movement is going to cause scar tissue to form on the artery. So a balloon expandable covered is like a VBX, which is a Viabahn balloon expandable. So just when you look at the boxes, they say Viabahn on them, so just don't get confused. A bare self-expanding would be something like, what do we use? We use Everflex or EV3. Everflex. These are just trade names. This is what we use at my hospital. There's a lot of different options, like an ICAS instead of a VBX, and other things that you can use, whatever. And then balloon expandable bare are less common. I can't honestly remember the name of the ones that we use, but if you need one, you can probably find it in the cath lab. And then just general notes. VBX usually is going to be on the order of 7 to 8 French. Most of your Viabahns are going to be in the 7 French range. Most Everflexes are about 5 French. And these are things you want to think about, because when you're thinking about your intervention, you want to know what your target is and how you're going to get there, and then what size you need. So let's say we have somebody who has a lesion here at their proximal SFA. So we're in the SFA, so we know we don't want to use a VBX because there's going to be a lot of movement. We probably don't even need a Viabahn. So we're thinking about a self-expandable stent. So we're really looking at a small platform like a 5 French. But if this lesion were up here in the common iliac and we're thinking about using a balloon expandable, then we need to be thinking, depending on what size it is, it's about 8 French when they switch over. From 7 French to 8 French. 8 millimeters, they switch over from 7 French to 8 French. So we need to be thinking about an 8 French sheath, We need to then have a stiff wire. And you just, yeah, that's pretty much it. So you just start working backwards from where you did. A lot of times with these VBXs, also know that the traditional way to deploy them is to bring your sheath entirely across the lesion. So let's just say we're going up and over for whatever reason. Get your sheath all the way across, and then get the balloon expandable stent across the lesion, and then pull your sheath back. The reason for that is these stents are crimped onto the balloon, so they can come off. And that's especially